Okay, so it's 6 o'clock. Let's start.
You got it.
Hello, everyone. Good evening or good morning, depending on where you are. I'm Frank from Wisonic Medical. You are so welcome to attend our Wisonic Global Webinar Deadline Program with a mission to widely popularize the point-of-care ultrasound utilization in medical practice, such as anesthesiology, pain management, MSK, intensive care, and emergency medicine, by in cooperation with different experts across the globe to do online webinars or in-person workshop trainings. So far, we have completed over 700 webinars nationally and internationally since 2020, attracted over 180,000 doctors attended, received over 3.2 million reviews and comments. This time, we are honored to have invited 8 renowned MSK experts in the United States to participate in our program, MSK Ultrasound Webinar Series. In these 2 months, they will present a comprehensive webinar series about musculoskeletal, including lecture topics on orthobiologics therapies and ultrasound utilization in MSK practice, covering common body parts like shoulder, elbow, hand, wrist, hip, foot, ankle, and knee. Here, I would like to express our most gratitude to these 8 respectable experts. Thank you. Till now, we already completed 6 webinars. So today is the 7th and also the last webinar of our MSK Ultrasound Webinar Series program. We invited Dr. Brandon Tazier as speaker and Mark Kessler as moderator to lecture with topic on ultrasound in MSK practice knee. Let me show you my screen here. Sorry. Mark Kessler has abundant experience in MSK and ultrasound. He starts MSK and the cardiac diagnostic ultrasound profession since 2008, became ultrasound consultant since 2012, and MSK instructor since 2014. He is member of several famous societies, like American Registry for Diagnostic Medical Sonography Society and the Society of Diagnostic Medical Sonography. Moreover, he is a regular moderator of all the 7 webinars in this MSK Ultrasound Webinar Series. So, Mark, could you please introduce today's speaker, Dr. Brandon Tazier?
Thank you, Frank. I appreciate it. Good evening, good morning, everyone. Thank you for joining us once again for another lecture. Tonight's lecture will be put on by Dr. Tazier on the knee ultrasound. Brief little description about Dr. Tazier. He's a current chief resident at Creighton University, Valley Wise Health Medical Center. He is also the vice president of the Emergency Medicine Residents Association and Sports Medicine Committee. His background academically is Doctor of Osteopathy from NYIT College of Osteopathic Medicine. He did his emergency medicine residency from Creighton University School of Medicine. He's also the sports medicine specialty track at Creighton University School of Medicine. He has a vast experience in musculoskeletal ultrasound and lecturing on guided joint injections and upper extremity splinting. He was a mentor for the NYIT Big Brother, Big Sister mentoring program. He has and is currently volunteering his time with the Ironman competitions, Nike Cross National Southwest Cross Country competitions, NAS Cup Series, high school and college football, as well as the BMX Winter National competitions. He's also volunteering at the New York City Marathon and many other events. He has published numerous papers in regenerative medicine, musculoskeletal ultrasound for the emergency physicians, and a lot more. He has lectured in pulmonary hypertension, neurotrauma, airway basics, GI bleeds, orthopedic emergencies, hyper and hypothermia, along with acute hand emergencies. Now let me welcome Dr. Tardia as he will talk about knee ultrasound. Doctor.
Thank you, guys. Let me see if I can share my screen here. Get it up right here. All right, can you see my screen? All right, sounds good. Thank you, guys. Thank you so much for Wisonic for having me give this lecture. I'm very excited to do it. I have no disclosures before I start here. So thank you so much for that generous introduction. I really appreciate it. So just a little bit more about me. So I'm an emergency medicine physician. I am currently located in Phoenix, Arizona. So this is the hospital that I work at. It's now called Valley Wise Hospital. So I'm credentialed in point of care ultrasound. So I'm a little bit different than some of the other speakers that that Wisonic has had so far for this MSK webinar series. That's been absolutely fantastic so far. The range, what I do right now and what I do for emergency medicine is credentialed in basically all areas of point of care ultrasound. So bedside ultrasound, point of care ultrasound is absolutely critical in the field of emergency medicine. We use it daily on almost every patient that we see, if not every other patient that we see. So we use ultrasound for point of care echocardiograms, so limited echoes that we can look at the heart, look at the squeeze, look for signs of heart failure. We use ultrasound to look for pneumothoraxes, to look at the lungs. You can look for pneumonias, for effusions in the lungs. We do it for eyes. I just worked a shift earlier and I did 2 just for the eye, and it's fantastic to look at all sorts of pathology all throughout the body. So that being said, today I'll be talking about musculoskeletal ultrasound and specifically for the knee. We use it all the time for musculoskeletal ultrasound in the emergency department and outside of it. So just a little outline of what we're going to be going over. We are just going to go over the uses of ultrasound first, the anatomy of the knee, the approach to the ultrasound evaluation of the knee, and then some common pathologic findings on ultrasound. And we'll go over that as we go. So just some advantages of ultrasound before we do it, because there's tons of other imaging modalities that we can do. There's X-ray, there's CT scans, or MRI. So why use ultrasound? So first, it's non-invasive. It's easy for the patient. No one likes to, a lot of people are claustrophobic. They don't love, going in the MRI machine. They don't love going in the CT scanners. But ultrasound, you can, bring it right up to a person's bedside, wherever they are. It's very easy. It's portable. It's great for the whatever practitioner or whatever provider is using ultrasound. It's very portable, very cost effective in comparison to MRI, CT scan, in terms of what you can see on it and the cost benefit to it. You can assess vascularity in real time on ultrasound. So you can do that using things like Doppler, which we do regularly, also color flow. So we all use it nowadays for if you have to do some sort of central line or other lines in the body. I mean, ultrasound is now standard of care, whereas, even 10 years ago, people were doing things without ultrasound. And nowadays, I would never dream to do it without ultrasound now. Like I said, you can get real-time assessment and evaluation, and this is critical because you can see some pathology, and then based off of what you see, you can then, do another scan if you need to. You can get imaging right on the spot. So you have that image right away versus, sometimes you have to wait hours to, get an MRI, get CT scans, things like that. And then let's not forget, it's very safe. There's an absence of ionizing radiation, that CT scans have. And then there's really no specific contraindications to doing ultrasound. There's not a lot of those when they're maybe in sort of pregnant patients, let's say for CT scans. So there's a lot of advantages, obviously. And then in musculoskeletal ultrasound, you can use it to evaluate for pathology. You can look at soft tissue defects. You look at fractures. You look for joint effusions. You can do it in every joint of the body. You can do it everywhere. It's very easy to do so. You just have to, you do have to put in the time to learn how to do it, because it's not something that you just pick up right away. But once you learn how to do it, it's definitely a game changer and sort of and will change your practice. So it's been great so far since I've been learning it. In terms of other things that you can use it for musculoskeletal reasons, you can watch your needle go in if you're doing injections. So you can do joint injections for corticosteroids for things like PRP or stem cell injections. You can use for arthrocentesis, whether that's for a diagnostic arthrocentesis or therapeutic. If someone has a large joint effusion and it's causing them pain, you can watch your needle go in and you can remove the fluid, and you can see that in real time. And then also it's used a lot for pain control. We do this all the time in the emergency department. So if someone has a fracture, you can use it ultrasound to guide the needle to do a hematoma block. For shoulder dislocations, you can do an intra-articular block. You can do it for other dislocations as well, but that's one of the common ones we do for the glenohumeral joint dislocations. And then any nerve blocks too for a region that's someone's having difficulty with pain control, and it's in a let's say like a forearm or a hand. You can do a radial nerve block, a medial nerve block, and that will help with pain control. And nowadays, almost all of these are ultrasound guided. So there's a lot of uses with ultrasound in musculoskeletal evaluation. Specifically to the knee, where you can use it to look at the joint anatomy, the tendons and ligaments. You can use that real-time dynamic assessment to look for snapping and clicking of joints. You can see, someone specifically has an area of pain that's in the lateral aspect. You can see exactly where it is. You can, palpate with the ultrasound probe as well to see if that is exactly where they're having pain. And then you can see on ultrasound what is going on directly underneath that. And then, specifically to the knee, a lot of people nowadays have knee replacements. And so that's always going to has some artifact, especially with like CT scans. And so you're not going to have that artifact that you can have with those. And there's the vascular structures in the popliteal crease that we'll go over a little bit later, but you can evaluate those. You can put flow and Doppler on those as well. So just before we start with the actual ultrasound, just a little bit of anatomy here. So the knee joint, it's a synovial joint. It's the articulation between the femur, the tibia, and the patella. In between, can you guys see my cursor here? There's some, if I'm moving it right here. Okay.
Yes, we can.
Thank you. So, this is where the meniscus is, menisci on both sides. On this picture you'd see it, but that provides the cushion for the knee joints. And then when we're looking into how we're going to go ahead and do the ultrasound evaluation of the knee, you can split it into 4 quadrants. There's a lot of different structures, but if you split it this way, it helps with having an approach to do it. So we can split into the anterior, the medial, the lateral, and the posterior quadrant of the knee. Before we do that, a lot of questions are always on what ultrasound probe are you going to use. So typically, we're going to use the high frequency linear array probe for musculoskeletal ultrasound, especially for the knee here. Sometimes if a patient has a larger body habitus, you might need to use a curvilinear probe or need to just to have a little bit more depth to see there. But for the most part, for the knee, the high frequency linear array probe is the one that you're going to be using. You want to try to, as much as you can, get a view in the long axis as well as the short axis. And so that way you can see, pathology or the anatomy in the 2 different views at least here. So if we break it down again by anterior, lateral, medial, and posterior, there's a lot of different structures that we can see. So this is just for the anterior. We're not going to have enough time today to go through every single one of these in each of the quadrants, but we're going to break it down into the most important ones when you're doing the ultrasound evaluation of the knee. And then, so here's just what we see for the lateral as well, the IT band, the lateral meniscus, the medial. You're going to have the medial meniscus, the MCL, the pes anserine tendon and bursa. And posterior, you're going to have you're going to have these structures here that you can evaluate. But again, we're not going to be able to go through all of these. So let's start with the knee, the anterior knee, sorry. So we're going to start with the anterior suprapatellar space. So when you're doing the anterior knee evaluation, you can break this up into the anterior suprapatellar, so above the patella, and then the infrapatellar space. So we're going to start with the suprapatellar space when we're doing this. So if we look here, this is just a diagram of the knee. So when we're in this anterior, so right here, the suprapatellar space is where we are. We're going to see the quadriceps muscle here. You see the tendon right here, attached to the patella. And there's a couple other structures that are really important here. So so you see this quadriceps tendon, like I was saying, but just deep to that, you're going to have the quadriceps fat pad right here, which is really important. It's something that we're going to see on ultrasound. And then deep to that, you're also going to have the prefemoral fat pad. But in between, you're going the quadriceps fat pad. It's also known as the anterior fat pad here. But in between those two fat pads, you're going to have this structure right here, which is the suprapatellar recess, which you want to evaluate as well. And then this is the patella right here, and this is the femur, obviously, in the tibia and the fibula. So when you're doing the evaluation for the anterior knee, you're going to have the patient supine to start, so lying on their back, and the knee is going to be in slight flexion, anywhere from like 15 to 30 degrees or 20 to 30 degrees in flexion. And by having them in this position, it's going to put some tension on the extensor mechanism of the knee, and you're going to help limit the anisotropy of the ultrasound, which is just going to be that angle artifact. If you have it at the ultrasound probe at the wrong angle, then that's going to cause a little bit of anisotropy, and you might not get the image that you actually want. So this is why you put it in flexion, a little bit of slight flexion. So so where do we start when we're when we're doing the suprapatellar space here? So we want to have the probe. It's going to be in the mid-sagittal region. So just like this picture is shown right here, in the long axis. So it's going to be long axis to that femur right there. It's going to be parallel to that shaft of the femur, and it's going to be just proximal to the patella. So the distal edge, so this edge right here, is going to be right over the proximal patella. And so if we look at that picture again, this is exactly, this is what it's going to look like. So so like I was saying, this distal edge of the probe is going to be over that proximal end of the patella. So then if we look at, just using this picture, what are we going to see underneath, or what should we see underneath of the ultrasound? So just underneath, we should see the quadriceps tendon right here. We should see that quadriceps fat pad. You possibly will be able to see the suprapatellar recess. And then right here below that, you should be able to see the prefemoral fat pad. And then you should be able to see that proximal edge of the patella. So that's exactly what we do see when we look at the ultrasound image when we're in that location. So again, probe, and you're seeing right here, you're seeing the quadriceps tendon, and then that's attaching. You can see that attachment right onto the patella right there. You're going to see the femur deep. And then right here, you're going to see that quadriceps fat pad. And then right here, it's tough to really tell, but this is the area that you're going to see the prefemoral fat pad. And like I was saying before, you should see, you might or you might not see that recess, that suprapatellar recess in between. And so you're not always going to see it, that recess, that space in between the fat pads. But if someone has a joint effusion or fluid where it shouldn't be, that's really going to show it a little bit more. So if we look again, quadriceps tendon is onto the patella right here. And then this is the quadriceps fat pad. And then this hypoechoic area right here, this fluid right here that we can see between the prefemoral fat pad and that quadriceps fat pad, that's going to be that suprapatellar recess, that space right there where that effusion can really just accumulate right there. And this image right here, I should have started that. So this is from ESSR guidelines of the knee. They're a great resource for ultrasound. So I have some images here. A lot of these other ones are my own, but this one is of the ESSR. And so it's a good image showing that recess right here. There we go, suprapatellar recess. And then, so that was in the sagittal plane, and then we're going to move to the transverse plane. And so we were sagittal here, and then just move 90 degrees to be in that short axis right there. And you're going to be just proximal to the patella, and you're going to be perpendicular to the quadriceps tendon and the femur. So again, using that same image right here, this is what the ultrasound probe is going to look like, and you should see underneath, you should see that tendon, you should see the fat pad, that recess possibly, and then the deep fat pad as well. And if we go in, so that's kind of what we're seeing. So in this area here, so you're not going to really always see that fat pad. You can see a little bit right here, but you're going to see the femur right here. But what you see is you see that tendon. And so the benefit of this view is you can kind of see all of the tendons of the quadriceps muscles, kind of where they're coming together to join onto the patella. So this right area, this is from ESSR as well, but this area right here, this is your rectus femoris. This is going to be the most anterior that you see, and that's going to be right underneath where your probe is. Then you have your vastus medialis, your lateralis, and your medialis as well, right there. And then, so if someone does have an effusion, it's going to look something like this. So you have that tendon here. This is you have the fat pad, and you have the joint effusion here as well. So this is where this is a good way in the suprapatellar. Having this in the short axis is really able to see this joint effusion. Specifically for me in the emergency department, we have this image we use ultrasound to get this view all the time. And because a lot of people, if they come in with swelling of their knee, we're going to do a bedside ultrasound. We're going to take a look in that short axis, and we're going to do an aspiration to see, is that a septic knee? Is it septic arthritis? Is it gout? Is it bloody? What is it exactly going to be? And so this is we usually do a lateral. This is a couple of different ways you can actually do the aspiration. This is just the lateral approach, which is probably what we do most frequently. And you can see under ultrasound guidance, you can see the needle tip going in. You can see it going into that fluid right there. And then, so this is safe for the patient because you're able to know where the needle tip is the whole entire time. If you're in that area, in that fluid, you're not hitting structures that you shouldn't be. So again, this is very critical to what I do daily, and then to anyone doing injections or aspirations as well. Ultrasound is critical for that. So then, still in that suprapatellar space right here, another structures that you can see, you can look at the medial and lateral patellar retinaculum. So this right here, you can see this is the retinaculum on these both sides, and these just help with stabilization of the knee, especially that medial retinaculum right there. So basically what you're going to do is you're going to shift the ultrasound. So instead of being just in that probe, just right in the medial aspect, you're going to shift it over to both sides here. And then you can see at this image right here where it's going to be. So where you're going to hold the probe, and it's going to be perpendicular to that femur right there. And so here you can see, so we see the femur right here, we see the patella, and this right here is going to be this is a picture of the medial patellar retinaculum right here. And you can actually see the medial joint recess as well here. And so that suprapatellar, that recess that we looked at before, you can have some fluid go on both sides, laterally and medially as well. And so this is a good way to evaluate to see if someone has, let's say, swelling just to the lateral aspect of the knee. You want to see if there's any fluid in that lateral recess, or in this picture right here in the medial recess. And you can look for any pathology of that medial patellar retinaculum in a patient that has like patellofemoral syndrome or any pain at the knee. This may be something that could be contributing to that. And then one of the last one we're going to go over here in that suprapatellar space is the trochlear view of the knee. And so from here, so we're going to this is the only one where we're going to change positions of the knee, or we have to change positions. You're going to have a full 90 degrees flexion of the knee here. And then that's, so you can, if this is the ultrasound probe, you're looking down at the trochlear groove. The patella is going to be more anterior to that. You're going to hold it in that transverse or short plane with it being perpendicular to the shaft of the femur here. And so when we look at the view here, this is the anterior trochlear groove that we can see. It's also called like the sunrise view here. But you can see the femur, you get a good view of the articular cartilage of the trochlea, and you can see the quadriceps tendon as well. So that's the last one that we're really going to want to see or there's a couple other ones, but this is some of the most important structures you're going to want to see for the superior patellar space. Now moving on to the infrapatellar space, we want to again identify some structures that we want to see. So we want to see the patella, we want to see the prepatellar, the anatomy, you can see the prepatellar bursa, and then the patellar tendon, and then right here you have the infrapatellar fat pad, or also the Hoffa fat pad, and as well you can sometimes, but not usually, see the superficial infrapatellar bursa, but this is just anatomy that you of the infrapatellar space. And then you do have right here, just deep. If you look right here in this picture, you see the deep infrapatellar bursa right there. So where you're going to hold the probe for this one, you're going to have it again mid-sagittal. You're going to have the leg extended again to that 15 to 30 degrees, and you're going to have it in the long axis, just parallel to the patellar tendon. And this time you're going to have the proximal end of the ultrasound probe. You're going to have that just over the distal end of the patella. And I should have stated before, but there's a bunch of different ways you can have that patient have like that 20 to 30 or that 15 to 30 degree slight flexion. You can just roll up, some sheets. If you have like a foam bolster or something, you can just put it right under there. There's a bunch of different easy ways to just get that slight flexion that you need. So let's see. So if we look at what the ultrasound is going to look like here, you should see underneath, you see the patellar tendon. You should see that infrapatellar Hoffa fat pad. And then possibly you can see that deep infrapatellar bursa here as well. And then you can see the patella there. So if we look at what it looks like under ultrasound when we're in that view, you can see right here, that's exactly what we're seeing. We're seeing the patella tendon and that its attachment at the tibia. And you can see that Hoffa fat pad or infrapatellar fat pad that's going to be just distal, just deep to the patellar tendon. And so this is another image from ESSR, because if we go back to this image, we don't see that deep bursa right there. We don't where it should be. We don't really see it. But this is a good image of looking more at that bursa. It should look like just a little triangular, if you do see a little triangular hypoechoic area, and to have a little bit of distension of that bursa is normal. You don't want to have too much distension. But if it's just a small distension and it's triangular in nature there, that is going to be, that can be absolutely normal. So that's the deep infrapatellar bursa. So you always want to try to see that if you can. This is just another view of that as well. You can kind of see that triangular right there. And it should be, you should see the patellar tendon, and then you should see that bursa, and you should see the proximal end of the tibia. So it should be right in between those. The patellar tendon and the tibia is where you're going to find that. And then if we're looking at the patella a little bit more, so you can look for things like patellar tendon tears. You can look for ruptures. This is just from a paper, and just shows this ruptured patella right here that it's showing. And so you can see that loss of nice fibrillar patella tendon structure right there. You just have this mess of this kind of hypoechoic area that does not look like that nice, neat tendon that we're usually seeing. And so you can identify ruptures or any tears in the patella tendon using this view. So then moving on, you can just rotate that probe again from being that sagittal to having it in the short axis view, and then you're going to have it right over the patellar tendon, the proximal aspect. And again, this is what it's going to look like in that view. And if we look here, we see the patellar tendon, and then you see that Hoffa fat pad underneath it, and you see patella. This view, you can get just a different image of the patella here. And you always want to scan when you're in the sagittal, you want to scan distally and proximally as well. So kind of go up and down all the tendons that we see and all the structures. You want to see the integrity of the entire structure, or the entire structure that you're looking at. And in this view right here, you can see the width of it, of the tendon. You can look to see if there's any, any tears, any abnormalities in that, in that shape of the tendon that we're looking at here. So you can see other abnormalities on this view that you're not going to see on just that other sagittal view or that long axis view. And then one last thing is, and so this isn't really going to be infrapatellar. This is just going to be to look at the patella itself, or this prepatellar bursa. So if you want to try to get a view of this prepatellar bursa, you're not. It's going to be difficult to get. If you do it, you want to put a lot of ultrasound gel just right on top of the patella itself. You can still have some flexion of the knee. You don't want to have too much flexion there, and you just want to float that ultrasound just right over the patella to see if you can see that prepatellar bursa. If you put too much force down, then you're most likely just going to push that out of the way because there shouldn't be that much space, that much fluid, and then you're not going to see that bursa at all. But you could see, you can evaluate the patella itself and look for things like fractures using ultrasound as well. So instead of seeing this this picture of this normal patella, this nice linear hyperechoic line right here, you have this abnormality right here that you can see as a fracture of the patella. You obviously are going to be you're going to know what they came in for, and you're going to take a look at it, and then you can possibly diagnose the fractures that just using ultrasound, just using that view. So now we move on. So the anterior, that's you're going to get a lot of information out of that anterior quadrant. The other ones that the lateral, medial, and posterior that we have here are going to be a little bit shorter that we have here than the anterior itself. But there's always tons of structures that you can look at. So this is a image here. This is from Netters, and so we blow that up a little bit more. We want to look at this lateral quadrant in a little bit more detail, and we can see some of the structures we want to look at. We want to look at the lateral meniscus, or the fibular. You can look at the fibular collateral ligament, or the lateral collateral ligament, the LCL, as most of us call it. You want to see the popliteus tendon here, and it's important to note. The only reason I like this picture here is you can see that where you're evaluating. So this LCL right here. So it's attachment onto the condyle of the lateral condyle of the femur. So it's going to be really right in proximity to that popliteus tendon. And so if you're if you're taking a view of the LCL in that area, then you can also take a look at the popliteus tendon as well. You can take a look at the lateral meniscus in this lateral quadrant view, and then also Gerdy's tubercle here. That's going to be on the tibia. And Gerdy's tubercle, another image by Netters here, is just where the IT band right here is going to attach to the tibia. So just going back to where are we going to have where are we going to hold the probe for these ones. So for this lateral quadrant, you can start, again, you're going to have the patient supine. You're going to have that 15 to 30 degrees flexion, and you're going to have slight internal rotation of the leg. And so if a patient is not able to have any slight internal rotation, you can also have them just try to roll kind of like on their contralateral side. So whatever is easiest for them and most comfortable. Obviously, if they have pathology in their knee, it might be a little bit painful to have them try to have internal rotation. So do whatever is most comfortable for the patient. And to start, you're going to have the probe parallel to the femoral condyle. You're going to have it so just posterior here to the patella, and then again you're kind of just going to move distally across that joint line. So you really want to take a look always like proximally and distally as we go through all of these. So this is a view here. So if we're over, this is a picture again where we're showing where our ultrasound probe is. That we can, if you have in that location, you can take a look at the lateral meniscus. You can see the IT band. In this view here, you can see the popliteus tendon. Achilles tendon as well here. And so if we look, we see the tibia, sorry, this should not say fibula here. I apologize there. That's the femoral shaft there. I apologize for that. But right here, as we're going, we can see the IT band run across here. And so at the top here, we're seeing the IT band. And right here, this triangular structure is the lateral meniscus. And so this is a good view right here, especially go over that joint line. You can take a look at the meniscus. You can see if there's any irregularities in that meniscus. If there's any, it should all look generally the same distribution of when you take a look at all these structures. So if you see any abnormalities, like an area that's more hypoechoic, or you see any irregularity there, then that can possibly be pathology. And so right here, this is going to be the tendon that we're seeing in this area here as well. And then if we move the ultrasound probe just a little bit more distally along the axis of the IT band, so as soon as you find it there, right up here, you can just follow it along, and then you go more distally, you can reach Gertie's tubercles, which in this area right here, and this is where it's going to attach. I didn't put it into this presentation here, but you can have some dynamic assessments here to see if there's any abnormalities of the IT band there. And then so if we want to take a look next at the lateral collateral ligament, so if we're in that location, this is where the ultrasound probe is. Then we're going to want to just swing that distal end of the probe here. You're going to want to swing it down right here towards the fibular head. And so just like that. So it's kind of, if you're following like a systematic approach to the knee, which I definitely recommend that you do when you're doing these ultrasounds, just get one way of a habit of doing it, and then kind of follow that the entire way. You can always, if a person has pathology and just the lateral aspect, you can take a look. But if you're just doing a full evaluation of the knee, really have a systematic approach to doing it. So if you're doing it in this approach, and you just took a look like over that lateral joint line, you saw the IT band, then you can just swing it over to the fibular head, which is going to be right there, and that you should be able to just palpate. You can always palpate the fibular head. It's one of the structures that you definitely should always be evaluating for the knee, as well as any ankle pathology as well. If someone comes in with a rolled ankle, you really want to feel that fibular head to see if there's any pain in that area. So then if you just go right over there, you should see the lateral collateral ligament. And then obviously, if you're not following the approach and you want to see the lateral collateral ligament, you can always just start with the distal end of the probe, the ultrasound probe, just right over the fibular head, and kind of angle it right to that femoral condyle there. And then you're going to try to see a nice linear pattern of the LCL, and you'll know you're in the right area. And I think that this was just a nice view. This is a good picture of why you're just going to angle it there. So again, if we're taking a look here and we see right here where you're taking a view of where the IT band is and where it's attaching onto Gertie's tubercle, then you just swing that over to the head of the fibula, and that's where you're going to have the LCL. And so you should see that as fibers go. This picture is obviously in a little bit more flexion than that 15 to 30 degrees that we want. But again, it's just showing that that's why you're going to swing that probe the way you are to find the LCL. So moving on to see what it actually looks like here. You're going to see in this view, you should see the nice linear LCL, and you should see the fibular structure to it, and you can see it attaching onto the fibular head right here. I don't have a picture here of the pathology. We'll get to that when we have the MCL. But again, if you have any irregularities in this in this view, then you should be able to you can take a look at the LCL. You might have some pathology there, and this is another one for all these. You can see if you can do dynamic assessment. You can put some varus and valgus laxity on the knee, and you can see if there is any abnormalities there. You can see if your ultrasound correlates to your physical exam findings. So then moving on to the medial knee here. The structures that primarily going to go over are going to be the pes anserinus, the MCL, and the medial meniscus. And so this is just a picture showing that. And this is another picture from Netter's, because this is going to show you that a little better of that pes anserinus we're going to see here. So the pes, so this is going to be the tendons of the semitendinosus tendon, the gracilis and the sartorius tendon, where they're all meeting. And then they're going to meet at that pes, and you have this bursa right underneath. And that's actually really what you're going to see on ultrasound and take a look at to see that that you're actually in the right area to know that's where the pes anserinus is. So if we just take a look at the position here again, you're going to have the patient again in that 15 to 30 or 20 to 30 degrees flexion. If the patient is able to have some slight rotation, external rotation of the leg. And again, you're going to have the patient supine. So for all of these, you have to remember one way, you're just going to have the patient supine so far and just have some, 15 to 30 degrees flexion of the leg, except for that sunrise view. Just look at that trochlear groove. For the posterior one, it's obviously going to be different, but we'll get to that. So then where we're going to put the probe, we're going to have the probe in the coronal plane. You're going to have it posterior to the patella. You have it along the medial joint line, and just you're going to have it parallel to the femoral shaft. And then you should get a view of the MCL or in the meniscus here in this medial quadrant. So again, here, you're going to see that triangular structure. That's the MCL. You should see it between the femur and the tibia. And here, you're going to have the medial collateral ligament. It looks similar, obviously, to the LCL that we were seeing before. And then if you look at some, just what you can see on ultrasound to evaluate for any pathology, again, you're going to see this is what the meniscus is. And like I was saying before, it should all look pretty homogeneous. But if you see any irregularities like this, and the person has some pain in the area, then that could be, acute tear. You can have chronic tears of the meniscus as well. But this is going to be the area that you're going to take a look at it, and you definitely can evaluate for pathology. And then if we're looking at MCL a little bit more, there's a lot of different studies now that are looking at the accuracy, of using ultrasound just for evaluation of MCL sprains, of LCL, of meniscal tears, and really using it to see, how is it when it's compared to MRI or other things that, definitely used to be standard of care. And then the sensitivity and specificity that's showing is actually it's very good right now for the MCL. You're going to see differences when you look in the literature, but it's very specific and sensitive to look for the tears. And so this is just for MCL. We can see a sprain here. This is patient right here. You see some abnormalities in the ligament itself there. You see a little surrounding fluid here. So this is going to indicate the person does have pathology. And then if we're looking at the pes, the other structure that we wanted to see in the medial knee, you're just going to follow it down, the MCL down. You can move the probe slightly anterior, and you can view the attachment onto the tibia. So here, like I was saying before, so you have the bursa, and then you have all of those three tendons that are coming and joining together. And really, when you see that bursa right here, this is that hypoechoic structure right there, that bursa. That's when you're in that right area, and that's where you're seeing the pes anserinus bursa. And then finally, moving on to the posterior knee here. This is going to be the last structure that, the last quadrant that we go through. But here's an image again from Netter's here that we can just take a look. And so there's, like I was saying, there's tons of different structures that you can look for. But this one right here, the biceps femoris tendon, can be seen in the posterior view. You can actually also see this in the lateral view. So depending, on how you want to do it, you can add this to your lateral view. Your lateral quadrant view with ultrasound as well, and you're just going to have it a little bit more posterior when you're taking a look with the ultrasound. But you can also see the biceps femoris tendon just in this posterior view, and this is going to be a nice view to take a look. So you can see it right here. that the biceps femoris tendon is going to just attach to the fibula, which is why we can see it in that lateral. So to do it, again, this is going to be the change. You're going to have the patient and you're going to have them prone now, so not supine any longer. You're going to have some slight dorsiflexion of the foot. For this view, you can have that dorsiflexion of the foot, directly on a bed if they're on it, and then that's going to help give you a little bit better view. It's going to bring that that biceps tendon just a little bit up closer to your probe, and you're going to limit the anisoscopy as well if you have a little bit of dorsiflexion of the foot there. And then you're going to have it over the posterior lateral aspect of the knee, just like we're seeing right here. And you're going to have the distal probe over the femoral head. So then if we're looking at see what it's looking like here, we can see that this right here, you're going to have the fibular head. And then right here, you're going to have these this structure, the biceps femoris tendon that you can see right here as those this tendon of the nice fibular structure is attaching right to that head. And again, you're want to do dynamic assessment. You're going to go up and down that tendon. You're going to see you're going to be going proximally and distally and see if you can see any abnormalities or pathology there. This is another one you're going to want to switch to the short axis as well to take a look to see if there is any pathology that you can see there. So this is a little different than the other structures that we've talked about so far. But right here, we're going to see we want to take a look in this the popliteal crease or the popliteal fossa, and we want to see the vasculature. And so want to see the artery, the vein. You can see the nerve as well. And you're just going to have this. You're going to have a little bit of dorsiflexion in the feet. For this one, you don't necessarily need to, though. You can have those feet just hang right off the edge if you want to. If they want to, if that's more comfortable. You're going to have that probe transverse just right over that popliteal crease. And then what you're looking at, really, you want to assess for the artery and the nerve and the artery and the vein and also the nerve. The nerve should be the most superficial structure. And then right here, this is going to be the artery here. And then the vein you can see here as well. The vein is going to be more collapsible. And when you're in this prone position, it's actually going to be a little bit more collapsed than if you had the person supine. So one of the reasons that you do this, you want to take a look here is you want to take a look to see if a person has a blood clot in their legs or a deep vein thrombosis. This is another study that we do all the time in the emergency department, just to look for any evidence of deep vein thrombosis. You're going to do at least 3 spots in the leg. If you're doing point of care ultrasound, 3 to 4 spots in the leg. You're going to do proximal, mid, and you're going to do this popliteal crease at least. When you're doing the ultrasound up and down the leg. And what you're doing is you're going to have the ultrasound probe just right in that transverse area, and you're just actually putting pressure and you're bouncing up and down along this area right here. So you're just bouncing up and down, and usually the vein should be nice and compressible. So any vein in the body, whether it's for an whether you're using ultrasound to place an IV or you're doing a central line, you should see that vein. It's going to be nice and circular when you see it. But when you press down from the top, the vein is going to collapse all the way, but that artery is going to still be just pulsating. And so that's how you're going to really be able to differentiate between the vein and the artery. All the time, I also put pulse wave velocity. I put that pulse wave or do M mode of the ultrasound. If I have any questions, if it is vein versus artery, and if a person is severely dehydrated or volume down, then a lot of times it's actually pretty difficult to know if it is the vein or if it is the artery. And so it's very nice to have that M mode, to have that pulse wave that you can place on. When you have 2 of them, because when you're very volume down, the artery can actually be pretty collapsible as well. So you put on that flow, you can actually see it, and you can see that the arterial flow. So going back, sorry, I digressed a little bit, but going back to the DVT here. So the popliteal crease, you're going to press down, if the vein is not collapsible at all, so again, it should collapse down right away. If it is not collapsible, then you're going to, then that's definitely, that seems like that's probably a deep vein thrombosis. There is a blood clot or something going on in that vein. And then this is important to know because, that can put the patient at risk for pulmonary embolisms or blood clots in the lungs, which is, definitely a feared complication. And so that's what you want to do for the posterior fossa right there to regulate the vasculature. And then last thing we're going to go over here is just looking again in the popliteal fossa. And so you should see the medial head of the gastroc muscles in the semimembranosus. So here's the medial head of the gastroc. So you're going to be in that popliteal crease, but you're going to have it a little bit like more medially as well. And you want to see that that gastroc right there. And then the semimembranosus you're going to see over here. And usually you're not going to see anything. But if someone has, pain in their posterior leg or they have any swelling, then you want to take a look to see if there's, a Baker cyst. And so classically, really what you're going to see is you're going to see this neck basically right here. And so you have this medial head of the gastroc right here. You have the semimembranosus right here. And right here coming out in between the two, you have a Baker cyst. And so this whole area right here, this is all just fluid where it should not be. And so this neck right here, this little area, that's classically what you're going to see in a Baker cyst. This is obviously a very, very large one, very dramatic, to see. Sometimes it's not always going to look like that. But again, you see that medial head of the gastrocnemius, you see the membranosus over here, and then you see this neck here, and then just this lesion in between the two right here. That's going to be indicative of a Baker cyst. So that's basically what I have for right now. I think it went a little bit faster than I was anticipating, but I'm happy to take any questions that you guys have. Thank you.
Thank you, Doctor, for the lecture. Appreciate it. We do have a few questions here. Let's get right to them. First question. When you inject PRP or bone marrow, do you inject from the suprapatellar aspect into the joint or from the anterior joint capsule?
Sorry, I muted here. So it's really going to depend on the structure that you're trying to target with this. You can do the lateral, but it's really just going to. Sorry, am I still on here? Did I lose you guys, or can I? Oh, there we
go. We can hear you.
Yeah, sorry. So you can do from the lateral aspect when you're doing, but it really just depends on the target you want to structure. Sorry, the structure that you want to target. And so if you want to, so for all of these injections, it just depends. So if you can do an inline approach. So if you're going to you can go just in line with the ultrasound probe, and you can watch that needle directly go in to see. You just have to make sure that it's directly underneath the probe itself, or you can do the direct approach. So if you know the specific area that you want to inject, you can have the ultrasound probe right over it. And so if you have the probe, sorry, it's tough to show, but if you have a probe, the marker right here, you can just do that direct approach and just really target the area exactly that you want to. So it just depends, on the area that you want to hit for any of these injections.
Sure, appreciate that. Next question. What are the benefits of using ultrasound versus MRI in imaging of the knee? Going by finding pathology, or what could we miss possibly with ultrasound versus MRI? Or what can we see better than MRI?
Sure. So one of the things I didn't go over on this is going through like the ACL and the PCL, and you can definitely see those on ultrasound. They're a little bit more difficult, and you have to spend a lot of time in order to get to understand, what you're looking at, and you can do it from the posterior aspect of the knee when you're taking a look at those structures. And there's a lot of research right now into looking at, into ACL and PCL and how specific and sensitive they are in comparison to the MRI. But what I would say is if ultrasound in general, it's going to be, it's very, if there is a limitation to ultrasound, it is user dependent, which we can say for a lot of things. And so you need, it all just depends on how much practice you put in. And if you are not someone that uses ultrasound regularly to look at things like the ACL, the PCL, then I would say that there's the chance that you would miss, a tear a tear or a rupture or something like that of those structures using ultrasound if you're not used to it. And people in the right hands, ultrasound is definitely going to be able to be used to diagnose those. And then same thing goes for any deeper structure. It's going to be harder to take a look at all the deep structures using ultrasound. And so MRI, I think, may have a benefit in those. But that being said, there's the ability to just take the ultrasound and take a look directly, at where the patient has pain, use what they have, take a look at the MCL, the LCL, and you can definitely diagnose pathology or strains or sprains from there. There's some study, I think the studies I showed before, there's upwards of 90%, 91, 92, 3% specificity and sensitivity to look for those MCL tears when you're looking at the MCL versus the MRI, which is really good. That's basically just right around where the MRI is as well.
Sure. Excellent. Next question here. When scanning a patient's knee, do you have them standing to get a little weight bearing on that? And I'm going to add a little bit to this question because I do a lot of orthopedics, and for weight bearing for total knee replacements, do you ever do weight bearing in your imaging of the knee?
Sure. So I do not specifically. So you might be have a better answer to that question, but no, I usually do not do the weight bearing for that.
Okay. Yeah, a lot of people don't, but some of the orthopods that we deal with do that. Next question here. In children, do you use ultrasound to look at the growth plates?
That's a good question. You know what? I actually personally haven't I deal with an adult population more so. So I personally don't have as much experience with just doing that with pediatrics, but you definitely can use it. I just don't, I personally do not use it as much in pediatrics just because I deal with an adult population.
Sure. Absolutely. Looks like we have one last question. Let's see, there it is. Can you describe the best method of diagnosing jumper's knee with ultrasound?
I don't know if I'm going to be able to talk too much about that, honestly. You're going to use like the dynamic assessments and see if they have any like snapping or clicking there. You can see if they have any like abnormalities like with that, but I don't specifically do that as much either.
Okay. Appreciate that. Looks like that is all the questions that we have for this evening. Dr. Tarzi, I appreciate all your time and lecture on the knee. I know I got a lot of great comments and questions during this event, so appreciate your time.
Absolutely. Thank you so much.
Frank, I'll give it up to you.
Okay. So Dr. Brandon Tarzi, on behalf of Wisonic Medical, thanks for your excellent presentation. The anatomic pictures and the ultrasound pictures inside your PowerPoint presentation are very enlightening. Thank you. And we would like to cooperate with you for more webinars and other activities in the future.
Absolutely.
So let's keep in touch. And Mark, thanks a lot for your efforts again. The questions you just asked helped us to know more valuable knowledges. Thank you.
My pleasure. Thank you, everyone.
And everyone in the broadcasting room, thanks for your watching today and your supporting on all of lectures of our MSK Ultrasound webinar series. I believe you must have gotten a lot of inspirations during these 2 months. And that is our vision and the motivation as well. So it's time to say goodbye. We will hold more activities in the future. Welcome to join us again. So let's stay tuned. Bye-bye.
Thank you,
Bye,
everybody.
everyone.